Welcome to the Jena Club of Cardiac Surgery Enthusiasts.
We are a group of young cardiac enthusiasts exploring the world of heart surgery from every angle.
From the lecture hall to the simulation lab
to the doctor's office, where we dive deep into patients' care.
We're here to share the realities, challenges and thrills of cardiac surgery.
We will talk about groundbreaking research and innovation in cardiac medicine. And yes, sometimes we will bring you the lighter side of surgery too.
Get ready for stories, insights and interviews from the heart of the city of science, Jena, Germany.
We are cardiac surgery enthusiasts and this is our podcast. Enjoy the episode. Some surgeons learn from textbooks. Joseph Coselli learned directly from the people who built modern cardiac surgery. He trained in Houston under Michael DeBakey, Denton Cooley and Stanley Crawford at a time when complex aortic surgery was still being defined. And not just learning techniques, but learning how to think, how to decide, and how to operate when there was no clear roadmap. In this episode, we talk about his personal training years, the unique culture of Houston, and the lessons he carried forward from the masters. We explore how he became one of the world's leading experts in complex aortic surgery and what really separates a good surgeon from a great one. For me, this conversation was a true honor. If you're interested in mastery, mentorship, and the evolution of cardiac surgery, whether you were a student or a surgeon or simply curious about excellence under pressure, stay with us until the end. It's my great pleasure to welcome Dr. Joseph Coselli.
Imre, thank you. It's an honor to be here.
Dr. Coselli, what initially drew you to the medicine? Was it a personal experience, a mentor, or a simply academic interest?
Well, it was serendipity, actually. When I was in college, I was headed to law school like the rest of my family. But I spent a summer working at the relatively newly minted Texas Heart Institute in the operating rooms of Denton Cooley. He's also a native Houstonian, and I knew him or got to know him through family. And so as a student from college, I guess right after my first year of college, I spent the summer there in the Texas Heart Institute. And once I'd never been exposed to surgery or medicine before that. And once I had an opportunity to watch Denton Cooley and his associates carry out cardiac and vascular surgery in high volume and high quality. And it was just an absolutely amazing experience. And before that summer was over, I decided I wanted to go through whatever it took to be a cardiac surgeon.
And in those early years, what personal traits helped you succeed in such high-pressure training environment?
Well, one of the things that I was exposed to individuals who were completely and utterly devoted to their professional careers of surgery and medicine. And also, I was exposed to individuals who had an unbelievably strong work ethic. You know, they came early, they stayed late, patients came first, they did whatever it took. They worked very, very hard, as did the trainees under them. And as a consequence, that sort of mentorship, it rubs off. And, when you're assessing what does it take to accomplish something, you learn very early on that's what you have to do. And I was prepared to do it, happy to do it. I enjoyed it and I loved it.
And your residency, as you said, at Baylor placed you in the direct lineage of surgical legends. What was the daily culture like among residents and faculty during that era?
That's a good question. I went to medical school down in Galveston, and I was able to do the 4-year program in 3 years. And then I moved on to a general surgery residency because that was the only pathway at the time, to spend 5 years in Michael E. DeBakey's general surgery program under the Department of Surgery. And he was the leader of that program, and he had many associates that we were exposed to. So we worked in multiple hospitals. The flagship hospital was the Methodist Hospital, but we also had the local Veterans Hospital, the local County Hospital, and the local, MD Anderson, which is a cancer hospital, Texas Children's, etc. These guys, again, were completely devoted to what they were doing. Dr. DeBakey was an innovator and a leader in the field. He had extremely high volume of clinical activity, but also was traveling around the world, representing and teaching what he did. They were inventing operations as on a daily basis, things that hadn't been done before. When they trained, there was no such things as cardiopulmonary bypass or Dacron grafts or any of that sort of thing. So they had to invent these things, and they were leaders in cardiovascular surgery, and that all that rubbed off on us. Now, the work ethic was extremely strong. We have work hours now that in residents are limited as to what they could do, but there was no limitation for us. So our usual rotations were 40 hours on and 8 hours off, month after month after month. And then there were times when, particularly on Dr. DeBakey's service, where either on the clinical service on what we call the floor or the ICU, you actually lived in the hospital for a few months at a time. So it was, from that standpoint, rather challenging, but we loved what we were doing. It was exciting, and we were kind of having a good time.
Dr. DeBakey was known for relentless pace and total surgical control. How did you respond to that intensity as a young trainee?
Well, obviously, it rubbed off on us. Dr. DeBakey at that time had 4 operating rooms he worked out of, and he had 4 associates, one assigned to each room, and he would move from room to room, and we were involved as residents in helping him organize, and taking care of literally over 100 patients in the hospital at one time, 20 plus patients in the intensive care unit, and then 60 to 80 patients on the so-called floor of the ward. And we helped. Our job was to help him organize all that as well as take care of them. And in the operating room, our responsibilities were, if you were assigned to a room, you took care of whatever happened in that room. But when you were done, you went to the other rooms to be sure they didn't need any help, and most of the time they did. So, the hours were long, but the work was fascinating. The patients were interesting, and it was just an incredible in-depth immersion into technical clinical surgery.
You have mentioned that Dr. DeBakey expected residents to know everything about a patient before entering the OR. What did Dr. DeBakey teach you about surgical preparation that still influence your pre-op planning today?
Well, he taught us that the patient came first, and that in order to have a good result, which was the ultimate goal, that the preoperative, operative, and postoperative care were on a clinical spectrum, all of equal importance. And in order to take care of the patient in the operating room, you had to know literally everything medically and clinically about the patient that was available. That there's no detail that was considered unimportant. And that what took place in the operating room was of critical importance, and that influenced postoperative care, which we were also involved in, managing the patients postoperatively, pharmacologically, ventilation, all the way to the time of discharge. We didn't require a lot of consultants because we as residents were responsible for and took care of all of that. And DeBakey was a tough taskmaster. He did not tolerate a lot of, I guess we'd call them mistakes or misadventures. So you had to be very, very careful and very, very precise in what you did for his patients. He had, in order to take care of so many patients, he had a pattern and a formula that you had to follow in general, so that you had a schematic or a background of the way he liked to manage patients. And of course, patients frequently didn't read the book and they would get off course, but that was just part of the experience. But in general, if you followed his pattern and way of managing various situations, even though he wasn't there, he had his hands on what was taking place with the patients and would have a good idea what happened to them. And as long as you manage the patients in ways in which he wanted patients managed, which obviously were clinically relevant, you got along with Dr. DeBakey very, very well. If you didn't, you could bring some difficulties on yourself. And fortunately, I accepted the situation. I love Dr. DeBakey, and I thought well of the way that he managed patients, and so I learned his routine and I stuck to it.
Yes. Could you tell me an untold story with Dr. DeBakey inside or outside the OR?
There's so many. Dr. DeBakey and Dr. Cooley worked together for 18 years, and they split up in 1969. And somewhere in the mid 1990s, they dedicated a medical school to Dr. DeBakey in Byblos. Byblos is a city or a town right outside of Beirut in Lebanon, and Dr. DeBakey's parents were Lebanese immigrants. Dr. DeBakey himself was born in Louisiana. And when Dr. DeBakey went over to Lebanon to participate in the dedication of that medical school, he brought some speakers with him. He brought myself, Ken Maddox, and George Noon, and his wife went along. So there was a small group of us went over there, and we gave talks and participated in the dedication of that school. And it was a time where I spent literally hours where Dr. DeBakey and I alone were discussing things. And one of the things that he went through was in great personal detail exactly his interpretation of what happened in 1969 with the split of him and Dr. Cooley. And it was just amazing to have that personal perspective. Another time we were in San Francisco at a meeting, and Dr. Crawford and Dr. DeBakey and the three of us went down to Chinatown to have dinner. And I got to sit there and listen to these two guys go back and forth and have a dinner and have a discussion. And it was just an amazing experience. And then another time in Chicago, I was with Dr. DeBakey and Dr. George Noon. Dr. George Noon ultimately managed to operate on Dr. DeBakey when he had his dissection. And I still remember Dr. DeBakey asking Dr. Noon how things were going. And he said, well, a lot of my referring doctors are retiring. And Dr. DeBakey said, well, that's not a big problem. He said, most of my referring physicians are actually dying. So just a lot of personal time with these guys. It was just an amazing experience.
And what was Dr. DeBakey like outside the operating room? Did you ever witness a different side of him, perhaps with patients or residents?
Yeah, he was when Dr. DeBakey was taking care of patients and working clinically, he was very, very strict and focused. There was no small talk. There was no personal interaction. It was all business, the business of the clinical care of the patients. Outside the operating room, he was quite a gentleman. He He never used foul language. He was always very pleasant. I watched him talk to patients. They loved him, and you could see why they loved him. He was very, very personal. He was brilliant. I mean, he was a genius in his own way. And I was with him out of the operating room on a number of occasions. One time was at one of his associates' ranches, and I wish we didn't have cameras back then like we do now. I had Dr. DeBakey. He had a cowboy hat on. He had a red bandana. He was in blue jeans and had a denim shirt on. He was just very relaxed and very pleasant. And at meetings, I would be with him, out of the country and out of town, and he was always very, very nice and pleasant. But when we were taking care of patients, there was no nonsense. It was all 100% focus and business.
And at the another side, Dr. Cooley, we all know Dr. Cooley's surgical speed was legendary. What was your first impression watching him operate?
I had never seen an operation, and the first operation I ever saw was watching Dr. Denton Cooley do a total arch aneurysm. I was mesmerized, literally shocked by the symphonic beauty of the way he technically managed tissue and suture and the needle, everything. He was to say that he was a surgeon is an understatement. He was a master technician, almost a unique talent. And it's the reason, like I said, that I became decided I wanted to be a heart surgeon. I knew Dr. Cooley differently than Dr. DeBakey. I knew Cooley much earlier than you know than Dr. DeBakey by many years. Uh, Dr. Cooley became more of a personal friend. He mentored me and supported me, my professional career. But aside from that, we would go hunting together. He loved to hunt birds. I loved to hunt birds. We had good times doing that. He loved to play golf. We played golf together, socialized, and again, both these gentlemen were much older than I was, but Dr. Cooley was a little closer than age, and we were both Texans. We were both born in Houston, so we had a relationship that was much different than what I had with Dr. DeBakey.
And what was the dynamic like between Cooley and trainees? Did he actively teach or lead more by example?
Both of them led more by example than a sectarian way of teaching. It was not considered to be an educational process that was anything other than a advanced educational experience. And so they were both, Dr. Cooley a little bit more, both amenable to answering questions and having discussions and carrying on, an intellectual discourse. But most of it was an immersion into the clinical experience, and very much of a mentor mentee. Pay attention to what's going on and learn. And we were totally involved in the patients. One of Dr. DeBakey, and as well as Dr. Cooley, nowadays we do shift work. The guy before you hands it off to you, and you hand it off to the next guy, et cetera, et cetera. You could never go to Dr. DeBakey or even Dr. Cooley and say, well, there was a problem because of the guy before me. No, that guy was you. And the guy today was you, and the guy tomorrow was you. So there wasn't handoffs in shift work. It was total responsibility. And if you accepted that and wanted to deal with it, you got to see how patients were managed from the first encounter till after they were discharged, and it was an invaluable experience.
And by the way, what was your training program back in the days? Because I just want to compare it with our in Germany nowadays. Did you start with the ward, for example, for 1 and 2 years, then ICU, and then fourth or fifth year in the OR. What was the structure of your training?
It was similar from a general pattern standpoint. In other words, the wards were focused on in the first year or so. The ICU and the emergency room a little bit after that, and then after that, it was more of a hands-on surgical technical experience, and then in the very latter part of it, it was a leadership responsibility where you led a team and managed a lot of patients and delegated it, et cetera, and responsible for the education of students. The biggest difference that I see now is that uh, a couple of things. One is the time devoted, for the hours in the day and the days in the week were far more voluminous than what we have now. There weren't any hours restriction or days restriction.
Yes.
Vacation was very, very limited, et cetera. Probably the other two things that really impacted our educational experience was we had an enormous amount of open operative technical experience. We got to operate a lot. Now where we do CT scans and tests and things, if there was any question, the patient just got opened up and explored, whatever. But we were operating a lot. And the second thing, which was an overlay on that experience, was we had an opportunity to have a lot of responsibility. In other words, today, where there's a lot of senior faculty hands-on, watching over your shoulder and involved in every aspect of things, we had um, an absolute minimum amount of supervision in many of our rotations. Not when you're working with Dr. DeBakey, but in the other hospitals, they were resident. They were resident run programs, and we did everything, and with minimal amount of supervision. There were many operations where there was no faculty. I mean, it was just us, and guess what? The results were good. We knew what we were doing. We were rail trained. We were prepared. We were technically, adept because we had had so much experience in our junior years, and it actually worked out very well. But the experience was very different than what they have to have today. We had a lot of responsibility.
Do you remember your first case as first operator?
Oh, that's a good question. I would have been at the VA. I would have been an intern, and it would have been something along the line of a hernia or of an amputation or something. But I had some great senior residents, and we had an elective schedule all day, and we would spend most nights. We would continue to operate on emergencies, so we were just working basically nonstop, and it was a fantastic experience. I still remember those residents. They were senior residents at the time. They've all gone on to have successful careers, and they let me do, as a very junior resident, they let me do a lot, and that continued throughout my entire program. The, the cutting and sewing we did was just literally it's almost you couldn't believe it today, but it was how things were. It was very different.
You just described my dream pathway, but I believe nowadays it's a bit impossible, I believe. And do you remember your first cardiac surgery case?
Yeah, well, yeah, I was at the VA hospital, and it was a coronary artery bypass, and I had already opened the chest, closed the chest, wired the chest, cannulated and things. When I was a college student, I was helping Dr. DeBakey's associates. I was first assisting on the cases. They were cannulating and doing operations, and so when I got around to doing it myself, I was seemed to be kind of okay. Anyway, I was resident, and it was a coronary artery bypass operation. And it went
And
very
when
well.
did
It was
yeah, yes. And when did you met Dr. Crawford first?
So that was an interesting thing. I rotated with Dr. Crawford as a general surgery resident during my 4th year, and spent some time with him and got to know him through that, because he had there was no vascular residents at the time, so he had cardiac residents or thoracic residents, and he had general surgery residents, and he had fellows that wanted to learn more about particularly vascular surgery. And so I rotated on his service as a general surgery resident during my 4th year. And I did not rotate with him during my thoracic residency, but when I started my 2nd year, so it was a 2-year cardiac residency program at the time. When I started my 2nd year, he asked me if I wanted to stay on as a junior faculty when I finished, and I readily accepted. And it was an opportunity of a lifetime, and it really was a very, very important aspect of my entire career to spend time working with Dr. Um, Stanley Crawford and as a junior faculty member in Michael E. DeBakey's Department of Surgery.
What do you remember about his process before a complex case? Was he methodical, or did he improvise, or mix of both?
Yeah, it was both. At that time, he was doing general surgery, peripheral vascular surgery, and cardiac surgery and aortic surgery. So our days would be we did many, many cases in a day, but he would do hernias, gallbladders, mastectomies, colectomies, whatever. And he'd also do carotids, abdominal aneurysms, aortobifims, fem pops, etc. But at the same time, we were doing a lot of cardiac cases, aortic and mitral valves, coronary artery bypasses, ascending aneurysms, ventals and roots, arch aneurysms, thoracoabdominal aneurysms, etc. And he had some basic principles about each operation that he would try to follow. But as you know, frequently the pathology takes a different path. And in his own mind, he had plan B and plan C and plan D. And as the operation evolved and the pathology would take us down a certain route, he would adjust his plan based on what occurred in the operation and what he found with the pathology. The reason I say it that way is because, imaging at that time is kind of hard to believe. Imaging was quite different than what we have now. It was not. We did okay. When you go back when I was a resident working for Dr.
Yes.
DeBakey, we didn't do CT scans. What we did is for, let's say, abdominal aneurysms, there was no ultrasound, so we did cross table laterals looking for displaced calcium anteriorly, or we did IVPs looking for displaced ureters, and if there was an indication either on physical examination or those studies that there might be an abdominal aortic aneurysm, then they got an aortogram. Used sometimes a translumbar aortogram, because we weren't using the Seldinger technique. So that was the early experience. And then, CTs came around when I was working with, Dr. Stanley Crawford. But we did arteriography on almost all these patients preoperatively, and we planned our operations from that.
What was the culture like in Dr. Crawford's OR? Was it quiet or conventional?
He didn't listen to music, and he didn't talk a lot. He was very, very serious. It was all about every single moment. Again, he was also a master technician. I mean, it was like a conductor of a symphony when he was operating, and everything was very serious and very focused. And he was a tough taskmaster. He didn't tolerate a lot of jocularity or jovial opportunities, when he was focused. And he also didn't tolerate a lot of I don't know how that'd be the right word, but a lot of mistakes or errors on our part. Everything had to be just right, and if it wasn't, then he was not pleasant about it. He was pretty strict. Outside the operating room, he was great. We had a lot of fun. I used to go hunting with him, you know,
Yeah.
many times a year during the hunting season. He liked to hunt birds. We both hunted birds a lot. He even went down to Mexico. But in the operating room and around patients, he was very serious.
He reportedly gave residents a long leash, so to say, in the OR. How did he balance that trust with patient safety?
He surrounded him. Let me put it this way: he surrounded him by people that were completely devoted to the way he wanted things done. And so, when I first started working with him, there would be, except for opening and closing and stuff, for the critical portions of the operation, he would come in the operating room and I would help him. He never, in all my 7 years working with him, the way he taught, he never actually first assisted and helped me do an operation. Not one time. it
Wow.
was it was either I helped him do it, I just did it. And so we evolved into myself doing more and more of the operation, working with the fellows and the residents. And then as he got more comfortable with the situation, he didn't first assist the residents very much. It would be my job to help them, technically work through the operations which we were doing. And he just had to be comfortable with it. And once he was comfortable with it, he spent less and less time in the operating room with us, and we just took care of the patients in a way he wanted them done.
I'm really curious about Dr. DeBakey, Dr. Cooley, and Dr. Crawford. How did they handle disagreement or surgical debate? Did you ever see them change the course based on another surgeon's input or point?
Never. Never.
I'm so sorry.
I never saw Dr. DeBakey, Cooley, or Crawford, any of them, at the operating table with any of the other ones together at the same time. That just didn't happen. You know, when I came around, Dr. Cooley and DeBakey had separated, and Dr. Crawford was beyond being his own man, and so that didn't happen.
Okay. I knew that the answer of that question, but I had to ask it. So let's talk
Never even
now.
crossed my mind that might occur.
In your 2002 Annals of Thoracic Surgery paper analyzing over 300 extent 2 repairs, you showed a marked reduction in paraplegia over the time. What specific intraoperative change most contributed to that improvement?
Okay, well, we carried out a prospective randomized trial of CSF drainage in the extent 1s and the extent 2 aneurysms. And we found that with CSF drainage done properly, that it reduced the incidence of postoperative paraplegia significantly. And we also, from double digits down to low single digits. We also identified that it could be used for rescue in patients who developed paraplegia, woke up okay, but then had paraplegia develop later, or paraparesis. The other thing that we were exploring, but this was more of a retrospective analysis, not a prospective randomized trial, of left heart bypass and the extensive aneurysms. And so those two things probably were the two most important contributions to reducing the incidence of paraplegia, as our experience evolved. We ran a prospective trial with CSF drainage with Dr. Crawford based in part on what Joe Cunningham was doing in New York. And that trial did not find a significant difference. We also used left heart bypass, and it didn't seem to make a difference the way he was using it. The CSF trial we ran with Dr. Crawford, because of our IRB at the time, we were limited as to how much volume we could remove intraoperatively. So, in other words, instead of targeting a CSF pressure and taking out whatever volume was necessary to achieve that pressure, what we did was they made us target volume. They were afraid we were going to develop intracerebral complications, and consequently we were limited. Secondly, they wouldn't allow us in that trial to drain CSF fluid postoperatively. But when I got around to running my own trial later, after Dr. Crawford wasn't in the picture anymore, we were able to get through our IRB the opportunity to target pressure instead of volume, and to target postoperative drainage 1, 2, 3 days, whatever is necessary. And when we did that, we were able to show that there was a difference. And so, combination of these things, just improvement in overall care. For instance, we began to learn that, blood pressure management was absolutely critical. With Dr. Crawford, we ran the blood pressure a little on the lower side because we were afraid of bleeding. But as we increased our experience, we targeted a little higher blood pressure because we were more focused on renal and spinal cord protection, and a little less worried about bleeding. And so you put all these things together, and it allowed us to have a reduced incidence of postoperative paraplegia and paraparesis.
Your work has defined many of the principles behind selective intercostal artery reimplantation. What do you see as the current threshold for deciding which segmental arteries to preserve?
Yeah, it's very interesting. Again, that's not a prospective trial, but retrospectively, when we analyzed patients who had intercostal artery reattachment, it significantly impacted postoperative spinal cord deficits. Dr. Crawford, in his way of thinking, took a different approach. The primary variable associated with paraplegia in Dr. Crawford's mind and in his work was the total clamp time, total ischemic time. So Dr. Crawford associated reattaching intercostal arteries with an increased clamp time, and consequently possibly deleteriously or impacting spinal cord ischemia in a way which was a little different than our thinking. My thinking was that the intercostal artery reattachment was worth the extra time it took. And when we look back on our analyzing 1,000 extent 2 aneurysms, we found that reattaching intercostal arteries was favorable with regards to paraplegia. In anatomic studies, it's pretty well been shown that in humans, in the normal pattern, that the intercostal arteries on the left side and between T7 and L1 were the ones that are most likely to involve the primary circulation to the spinal cord, the so-called artery of Adam-Kiewicz. The interesting thing is, I think you have to keep in mind is that we don't operate on normal anatomy. We operate on pathological anatomy, which has probably rearranged some of the intercostal circulation to the spinal cord. But in general, if you follow the principle of T7 down to L1 and on the left-hand side, the other things that we look for are arteries that are large and arteries that don't have significant back bleeding. In other words, that they don't have collateral circulation to them. So we focus on those primarily. And patients with aortic dissection are more likely to have patent intercostals. Patients with intimal atherosclerosis and fusiform aneurysms are less likely to have patent intercostal arteries. I think in these high quality CT scans or MRI scans, we can identify preoperatively intercostal arteries that we when we are technically repairing the aneurysm that we can target and that we think are high target values.
What's your
We've done,
preferred med? Yes.
let me go back a little bit. I've with Dr. Crawford, we ran some trials with the somatosensory evoked potentials, SEP monitoring, and we found, at least in his work, on his cases, that the false positives and false negatives just really weren't helpful. I've looked at motor evoked potentials in several different groups of patients, and again found that if it simply didn't alter what we were doing enough to make it worthwhile. And I know other people might disagree with that, and I don't have any. We're not dogmatic about it, and maybe in certain situations, it it has value, but we don't currently use MEPs.
And what's your preferred method for renal protection? Cold perfusion via direct cannulation or selective visceral perfusion or another technique?
Well, we have initially we were doing nothing, and then we began to use cold crystalloid, lactators ringers with some mannitol and steroid, and we carried out some prospective randomized trials that showed that if you cool it down with cold crystalloid, that it statistically significantly reduced the incidence of postoperative renal dysfunction. And then we ran some cold blood versus cold crystalloid, and it was basically about the same, cold crystalloid being less expensive and easier to manage. So we used that. And then we followed the group in Milan at the San Rafael Hospital, Roberto Chiesi and Germano Melisano in their custodial or custodial formula for renal protection. And then so we adopted that over the last few years. If you look at they did a prospective trial, and it reduced the incidence of postoperative renal dysfunction. But if you look at severe postoperative renal dysfunction, it wasn't statistically significant, but it was helpful. So I think you have to recognize it has some limitations. We're currently using more of a left heart bypass with an oxygenator in circuit with oxygenated blood normothermic perfusion of the renal arteries right now. So we're evaluating that to see what it'll do to protect the kidneys. It may or may not have a significant impact over cold custodial, but it may be just as good, and also have in general some other favorable effects. But we're still analyzing our data on those cases right now as I speak. So we're still flexible and still looking for. We've done much better actually in reducing paraplegia than we have been on protecting the kidneys, partly because most people start out with a pretty normal spinal cord. But when it comes to renal function, a lot of our patients, they have only one kidney, or they've got renal stenosis on one side and have an atrophic non-functioning kidney, or they've had a kidney removed, or they have a creatinine of 2 to 3 to begin with. So renal function is a much more challenging preservation situation.
And how do you manage aortic reconstruction in patients with chronic dissection who develop thoracoabdominal aneurysms? Do you modify your fenestration or septum fenestration strategies intraoperatively?
Yeah, we open the aorta up and remove the wall between the true and the false lumen. So we're taking a dissection with two lumens and in effect creating a single lumen. And then the techniques are we do the proximal anastomosis, move the clamp down because in dissections frequently we're clamping above the left subclavian. And I think you have to recognize the contribution of the vertebral artery to the anterior spinal artery circulation. So then we reattach the intercostal arteries and move the clamp down again. So that's a contribution. And if you use a multi-branch graft that's prefabricated, you can do the distal anastomosis next. And now you've restored flow to the internal iliac arteries. Again, contributions to the spinal circulation. And then go about taking care of the renal and visceral vessels. If the kidney function is poor, we try to do both renals first and then the viscerals because of the tolerance difference. Otherwise, if the renal functions just fine, we're perfusing the left kidney. So we'll do the general pattern is to do the right renal artery graft, celiac and SMA, and then finally the left renal.
You have discussed a staged approach to reduce ischemic burden. In which anatomic situations do you favor two-stage versus single-stage thoracoabdominal aneurysm repair?
There's some patients that absolutely have to have an open operation, and well, I'm talking about staging the actual thoraco as opposed to staging the arch of the thoraco. Is that your question?
Yes.
Okay, so a typical one would be a patient with poor lung function, but still a reasonable candidate for open operation. What we might do is do an extent 4 because you can do it through a lower intercostal space, which is better tolerated from a pulmonary standpoint. And leaving a landing zone above the celiac axis and then come back with an endovascular stent graft. So that's one way of staging it. And also you can stage it going the other way as well. So we're always thinking about leaving landing zones for potential endovascular therapies down the line should they have progression of disease and require further treatment. Where as far as we're very liberal in our use of elephant trunks when we replace the arch. It's an excellent landing zone for endovascular therapy or open therapy, and we use the Thoraflex graft a lot for that. We used to use the Sienna graft with a Gore graft inside it, but now that the Thoraflex is available, it's just too convenient not to do it. It's expensive, and I don't like that aspect of it.
In your 2016 publications presents a comprehensive strategy for spinal cord protection. Of the 5 modalities you use, which has had the greatest impact in lowering paralysis risk?
Yeah, the single biggest impact, I think, is CSF drainage. Left heart bypass or some bypass of your choice is probably the second thing. Reattaching intercostal arteries would be number 3, but also very, very critical. And I think together these things, the important part is to in a patient who's at high risk for a spinal cord problem, using all of these modalities is important. Temperature management, blood pressure management, coagulation management, all of these play an important role. But CSF drainage would be the most important one that we've shown makes a difference in the high risk patients.
What is your technique for proximal aortic clamp placement in patients with heavy calcification or previous arch surgery?
Well, first of all, if I can't get a clamp on because of calcification or scarring or lung adhesion, you just can't free it up, then we'll use cardiopulmonary bypass, cool the patient down, and do the proximal anastomosis under circulatory arrest. You have to have that technique available to you. Otherwise, I think in the process, if you can, we'll clamp proximal to the left subclavian frequently. On occasion, I'll even clamp proximal to the left common carotid artery, but that's rare. My preference, of course, is to clamp distal to the left subclavian artery, if at all possible, and that can be available in many patients. Less likely with dissection, but I think the important thing is, if you can't clamp safely, then you just have to cool them down and put them under circulatory arrest with cardiopulmonary bypass, and be able to manage that. I think when you do that, then you put the clamp distally and perfuse the femoral artery or distal at when you're under circulatory arrest, and perfuse at about 2 liters, and then you get filling of the venous side, which then backfills into the ascending in the aorta and transverse aortic arch, interestingly, which then helps part of the cuts down on the risk of air as well as embolic debris, which would be a potential for stroke.
Well, let's talk a bit more about training. I'm really curious, what is your opinion about that topic, that nowadays in cardiac surgery, a resident or a trainee or a board certified surgeon should be 100% involved in science. What do you think about that? Because there are a lot of surgeons who think that cardiac surgery is cut and sew. What is your opinion about it?
Well, a lot of it has to do with where you are. So I'm not really sure exactly how this is managed in Europe. I got a pretty good idea how it's managed in Canada, for instance. But when we were coming through, we were general surgeons, general thoracic surgeons, and cardiac surgeons, and vascular surgeons. Nowadays, that doesn't happen like that anymore. General surgery is general surgery, vascular surgery is vascular surgery, and we take cardiothoracic surgery and we split it off into general thoracic, lung, esophagus, etc., and then cardiac, which is valves, coronaries, aorta, etc. So there's more of a focus on that sort of thing. When we actually had a paper on this from the American Board of Thoracic Surgery at the recent AATS meeting, and it did show that surgeons out there doing this work are more specialized now than they were before, which just makes sense.
Yes.
Having said that, there's different career patterns. We have in our country an opportunity for just clinical work, to go out into the community, smaller hospitals that don't have training programs, but just provide a service to the community. You need a coronary bypass, they do a coronary bypass. You need an aortic valve, they do an aortic valve or a TAVR, or mitral valve repair, or whatever's necessary. And there's nothing wrong with that. We have another group of doctors, surgeons, who are more a different kind of professional career, which involves training the future surgeons to go out and either be academic and or clinical community. And our program, for instance, we train both. Some of them are going to become academic surgeons. Some of them are going to be just clinical community surgeons. In order to train academic surgeons, you have to be involved in research, clinical research, laboratory research, etc., and expose the residents to that, because that's going to be part of their future career. So they're exposed to training because they're in the training program. They're exposed generally in part of their education to basic science research, but at least clinical research. And they go to meetings, present papers, develop abstracts, and that sort of thing. So you have different approaches. For instance, we also train people that even though they do some clinical research, that ultimately what they're going to do is go out into the community and just practice good cardio or good cardiac thoracic surgery. And we have 2 training tracks here for our program, and most of them do this. Train primarily in general thoracic or primarily in cardiac, But to be board certified, both of these merge into the same examination to become certified through a written examination and then an oral examination, and then they're continuing certification 5 years, 10, and 15 years down the line is more specialized into what they're doing. If they're doing congenital surgery or general thoracic or cardiac, so it's a mixture of a lot of different things, and we're trying to, I guess, serve a lot of many different purposes, but it all seems to work.
We spoke about your mentors, but you are a mentor of hundreds and thousands of residents in USA and all around the world. What are the early signs, or so to say, the green flag, sorry, that a resident has the mindset or temperament to become a great surgeon? What is your opinion about it?
Yeah, that's an excellent question. I'm not really sure what the answer is. Well, first of all, they have to have the intellectual capacity, but by the time they get to being a resident or a fellow in our situation, they've already demonstrated that they have the intellectual capacity. So that's a set aside. Used to be when they came out of the kind of general surgery programs and things that we had, the technical capabilities were important, and people without them got weeded out. They ended up just doing other things. When I started general surgery, there's like 13 or 14 of us. Only about 4 or 5 of us finished. The rest of them just did other things because they just didn't, for whatever reasons. There were a lot of different things. Things happened. So they have to have the clinical technical capabilities to technically do these kinds of operations. The technical capabilities of somebody doing an esophagectomy versus a thoracoscopic lobectomy or an aortic operation or a complicated diabetic coronary bypass, these are all different. So the way things go now is these individuals, to be really, really good, they have to recognize that ultimately, if they're going to have an academic, high-end situation and become what you call a great surgeon, etc., they have to accept the fact that they need to do a lot of different things, but ultimately become an expert and specialize in something. Dr. Crawford, when he would describe this, he says, you need to find something to become recognized as an expert. And his suggestion, it was metaphorically speaking. So he would say, become a brain transplant surgeon or something, But what he was talking about is, focus on the aorta, the lung, the heart, the valve, something, so that you can be recognized in that field and contribute and become innovative and push the field. You can't push the field every single thing forward, robotic this and this, but find something that you can contribute and make the specialty better through your research and your experience and your teaching, etc. So those are the things that I think that have to fall together.
Are there specific behavior you look in the first few weeks, so to say, of working with a trainee that signal long-term success?
Yeah, early on, you can tell how technically good somebody is just if they're helping you, how they move their hands, how they handle tissues, how they tie knots, how they hold this, that. You can tell pretty easily. Secondly, you have some people in the operating theater, in the actual technical aspects of an operation, are proactive instead of reactive, and you can pick up on that pretty quickly. Also, you can what you're looking for is somebody who stays calm, because the kind of work that we do, things do get interesting from time to time, and it's very important, when things aren't going well, for the operating surgeon to sometimes slow down and to be calm and in control, because then that permeates to the perfusionists, the nurses, the assistants, anesthesia, and everybody. So that's a critical thing, that we look for. Um, you can tell early on if somebody has, I guess, if you're a coach and you've got a bunch of kids and they're trying to, you're playing a sport, you can tell pretty quickly which ones are going to be good at it and which ones they're going to be okay. The ones that are going to be the stars, you can notice it pretty quickly. And partly there's a lot of things and aspects to it that are probably hard to put into words, but you've been doing it long enough, you know it when you see it.
Yes. Dr. Coselli, as we are heading to the end point, unfortunately, of our conversation, I can talk to you like for hours, but I appreciate your time so much. It's a dream come true for me to have that possibility to speak with you. I have one last question. If you could give a message or advice to all cardiac surgery trainees all around the world, what it would be?
Wow. There's probably so many things, but to your comments, you have to understand that it's truly an honor for me to sit here and talk to you today. It's a privilege, and that you would find what I might have to say respectful enough that you would take your time and effort to have me join you. So it's truly an honor. So to trainees, I think they need to recognize that the future of what they do is going to be different than what we train them to do. In other words, the operations that they do while they're residents are probably not going to be what they do 20 years from now and in the peak of their career. That was the case for my mentors, and it's the case for myself, and it'll be the case for them as well. So they need to have a strong general background and be willing to take their practice and their professional career in such a way as that they understand that it is going, if they're going to be successful, it's going to have to evolve into what is necessary 10 to 20 years from now. They have to be willing to adapt their clinical practice to that process. And if they really want to have an interesting professional career, they want to be one of the people that innovate and help develop those changes, which ultimately will make what happens 20 years from now not only different than what we do today, but better, with better results and better effects on the patients and the families that we take care of.
Dr. Coselli, thank you very much.
Tamar, it's an honor to be here with you. Thank you for taking your time to spend some time with me.